Hi everyone, welcome back to UWorld's Next Gen NCLEX Review. My name is Samantha, I am a nurse here at UWorld, and I am so excited to be back with you guys today. So in today's lecture, we're going to be looking at chronic kidney disease. Kidney issues are going to be so prevalent in the clinical setting, so if you're planning on working inpatient, this topic is one that you're going to want to be comfortable with. For all of our NCLEX preppers, there will be questions sprinkled throughout today's video, as well as NCLEX style questions at the end. We have a special bonus surprise question for you guys today, so we're doing 3 at the end as opposed to our normal 2. Let us know in the comments if you're planning to test so we can wish you good luck, or if you've already tested so we can congratulate you. So you guys know this live will be on demand on all of our social channels after we're done. I personally find our YouTube channel as the easiest one to search, so if you want to drop back in, use it as a future reference, you are of course welcome to do that. As always, drop your comments and drop your questions into the chat feature. Our content experts are standing by. They're excited to hear from you. Nurse Coley is moderating for us today, so she wants to hear from you guys. Stop by, say hi, and of course, drop your answers to today's questions into the chat. Speaking of that, let's go ahead and start out with a question to get us all warmed up. So we're talking about chronic kidney disease. What are the 3 main functions of the kidneys? Let's get the chat started out by letting us know the 3 main functions of those kidneys. Let us know. I'll give you a few seconds to go ahead and drop those answers into the chat. If you can only get 1, not all 3, absolutely no worries. We're happy. Meet us in the middle. Let us know what the 3 main functions of the kidneys are, even if you can only name a couple. And I'll let you guys go ahead and do that. I see we have a lot of testers in the chat. Someone's taking it on April 15th. Good luck. Someone else on April 9th. I see an April 14th and a 6th of May. So good luck, you guys. You're going to do wonderful. Let's go ahead and get that chat started by letting me know what the 3 main functions of the kidneys are. In the meantime, we go live 3 days a week, Tuesdays, Wednesdays, and Thursdays. We do Tuesdays a lecture series like we're doing now at noon Central Time. And then we're back with question drills on Wednesday and Thursday at 11 a.m. and 3 p.m. Central Standard Time. But I see lots of answers coming in. A lot of filtering, which is absolutely, you guys nailed it. We do filtering, remove waste, filter blood, filtering urine, filtration. Way to go, guys. You really kind of got exactly what I was looking for. So how we split up the functions of the kidneys, we're going to hop to a great excretory system image. Again, anything that we put up here, you guys are free to screenshot, take with you. But the kidneys are going to excrete, filter, and produce. That's how we divide up their functions. So let's look a little bit more closely at these. They excrete the body's toxins. They filter, deciding what should the body hang on to, what should it get rid of. These include elements like electrolytes, fluid, and waste products. And lastly, produce. I feel like this is more of a little known job that the kidneys have, but the kidneys produce a really important hormone called erythropoietin. This is both produced and emitted by the kidneys, and it plays a big role in the body as a whole, so its role is much larger than just the kidneys. It signals the bone marrow to release red blood cells when our red blood cell count is running low. A great way to remember the function of erythropoietin is by linking it and breaking it down to its components. So the medical name for a red blood cell is an erythrocyte, which makes erythropoietin a little easier to remember because remember, it stimulates and signals the release of those red blood cells. Alrighty, so now that we have some background to really pave the way, let's go ahead and jump into the pathology of chronic kidney disease. So it is a slow onset like this. You may hear it referred to as an insidious disease, or one that really just takes a long time to progress. That's really all that means. So this disease can take years to progress into end stage. We would call this end stage kidney disease, ESKD, or you may hear it called end stage renal disease, or ESRD. But it's important to remember that the damage done in chronic kidney disease is irreversible, meaning once that damage is done, there's nothing we can do to go in and undo that. So how do we classify CKD? We classify it in 5 different stages, and these classifications are made using something called glomerular filtration rate, or GFR for short. So the higher up we go in these stages, the worse the kidney breakdown is and the lower the GFR is. So remember when we discussed the functions of the kidneys, and to filter was one of those 3 main functions, the filtration that we're referring to happens in a part of the kidney called the glomeruli. Again, you can reference this chart we put up for you all, the table to see the excretory system, but that glomerular filtration rate, or GFR, is going to calculate the amount of blood that is filtered by the glomeruli, and it's measured in milliliters per minute. So going back to those 5 stages of CKD, the higher the number of the stage, the worse the damage. So stage 5 is much more severe than stage 1, and at each stage that GFR is further decreasing, so it's getting worse and worse. So in stages 1 through 3, here the kidneys are still functioning, but that GFR is decreasing still. So key nursing interventions here are going to include assessing the damage, monitoring closely, and most importantly, preventing further disease progression. Because we know the further along we go, the more severe it gets, and we can't undo that damage. So in stages 1 through 3, our biggest concern is preventing the further disease progression. Now in stages 4 and 5, unfortunately, our kidneys have become severely impaired. At this point, we're starting to consider more invasive options like a dialysis or potentially a kidney transplant. So what are the causes of CKD? Our most common red flag causes I want you guys to remember are diabetes mellitus and hypertension. Whenever we see diabetes, hypertension, think kidney issues. These 3 are kind of like a triangle. Usually where there's 1 or 2, you're gonna find the third. They're all very closely interrelated. So why is this? In diabetes, we see a constant state of elevated glucose that results from this diabetes. And what that can do is it damages the tissues of the body, and it can specifically damage the tissues of the kidneys. Now, hypertension also plays a role here. Consistently high blood pressure, blood flow can damage many different tissues of the body, specifically lots of the body's blood vessels and arteries. Now, the most important artery that feeds the kidneys is the renal artery. When this artery is damaged, it's going to limit that blood flow to the kidneys, which in turn will decrease kidney function. Remember when we talked about GFR and the amount of blood that those glomeruli are able to filter? Well, if our blood flow is decreased and not enough blood is flowing through the kidneys, the glomeruli are not going to be able to filter it. Other causes include autoimmune diseases like a glomerulonephritis, and a genetic disease called polycystic kidney disease can also lead to CKD. Alrighty, so now that we talked about the causes, what are the clinical features? So let's go ahead and pull up our clinical features table. So a big thing we're going to see in these clients is volume overload. Essentially, these kidneys are not working at full capacity. They're not excreting what they need to be excreting, and this is going to manifest itself in a couple of different ways. So that volume overload can manifest as peripheral edema. So we can see just a generalized puffy appearance, puffiness in the ankles and in the feet. Excuse me. It can also manifest as pulmonary edema, so we can hear rales upon auscultation. These are also sometimes called crackles. It's kind of like a popping, light crackling sound. I think of Rice Krispies and Snap, Crackle, Pop. Pleural effusion is another way that volume overload will manifest. This is when fluid has infiltrated that pleural space in the lung, which is going to limit the lung's ability to expand, which means it limits the amount of air a client is able to inhale. That's really going to have an effect on our respiratory system. And lastly, hypertension. So volume overload, essentially we have more volume that's circulating in a system of the same size, and this is going to push that pressure up, and we're going to see hypertension. Alrighty, are you guys doing all right? So we're going to move on to our next clinical feature, which is the accumulation of waste. Remember, the kidneys filter and excrete, so we can see pruritus, which is when toxins accumulate in the blood because they're not being filtered out by the kidneys, and eventually they make their way into the interstitial space. When they end up coming up to the surface of the skin, the client may experience some dryness and some itchiness as a result. We can also see the buildup of toxins in the blood impact the neurological system, and this can look like lethargy, sleep changes, peripheral neuropathy, which is that numbness and tingling typically in the feet and the hands. And a big thing we'll also see are changes in the electrolyte balance of the body. So because these damaged kidneys are not able to properly do their job anymore, we can see the accumulation and the lack of certain elements in the blood. So we can see high serum potassium being hyperkalemia, high serum phosphorus and low serum calcium. So we'll brush a little bit more on this later, but important to remember, potassium imbalances cause cardiac dysrhythmias, so this is really going to be a red flag for us. Another clinical manifestation can be disruption of that acid-base system. Toxins and electrolytes will accumulate in the blood, leading to increased blood acidity, which is a state called metabolic acidosis. And we have to brush on anemia as another clinical feature of CKD. So remember when we talked about that hormone, the one that the kidneys produced right when we started today's lecture? It's the one that stimulates the bone marrow to produce more red blood cells. Well, I'm going to ask you guys a question. Who can remember the name of what that hormone was? It's kind of tricky. No worries if you spell it wrong, but I'll give you a hint, and this is a big hint. It's related for the medical term for the red blood cell, which is called an erythrocyte. So again, what was that hormone we talked about that the kidneys produce? Alrighty, and I see lots of answers coming in, and you guys, per usual, are spot on. It was erythropoietin. So erythropoietin is what stimulates the production of the erythrocytes, or the red blood cells. So when the kidneys are not functioning properly, they're not going to be producing this hormone at a large enough rate, and no red cell production equals anemia. So this is an important one to note. Another result of CKD can also be bone diseases such as osteoporosis, and this is related back to those electrolyte imbalances, specifically low serum calcium or hypocalcemia. Alrighty, great job you guys. So now that we talked about all of these gnarly effects we can see from the CKD, what can we do as nurses to help these clients? How do we manage CKD? So we're gonna pull up our management table. It's pretty simple, but management here is twofold. We're gonna look at diet and we're gonna look at medications. So really important to remember is that this really only applies to stages 1 to 3, because here the kidneys are still functioning, they'll still respond to our treatment, but our big goal is to prevent further disease progression and try to not get it into that stage 4 and 5 CKD. So let's start out with our medications. What are we going to do pharmacologically for these clients? So we're going to treat that hypertension. We're going to give ACE inhibitors or ARBs, which are angiotensin II receptor blockers. And we're really going to aim to decrease that blood pressure to help prevent further damage to the renal arteries that feed the kidneys. Again, we have that volume overload, so we know we have a proclivity for higher blood pressure. So it's so important to reduce that. We're giving ACE inhibitors like our prils, lisinopril is a really common example, or ARBs, which are our sartans, like a losartan is a really common medication. We're going to treat that anemia. So we may give these clients iron supplements. We may give them erythropoietin injections because we know their kidneys are not producing enough on their own. And this will help stimulate the bone marrow to produce more red blood cells again to treat that underlying anemia. We're also going to work to treat the volume overload with some diuretics and reduce the general edema, only again in stages 1 through 3, because here the kidneys are still functioning. They're still able to respond to those diuretics and excrete the excess fluid. But important to note is that we have to watch this closely because diuretics are pretty tough on the kidneys. We also want to help to fortify our bones. So we're going to give calcium and vitamin D supplements to help supplement for that low serum calcium or hypocalcemia. And we're going to treat the electrolyte imbalances. So really important here is to pay attention to that potassium imbalance, specifically the ability for the body to go into a state of hyperkalemia during CKD. So we know that potassium in hyperkalemia has cardiac complications, specifically cardiac dysrhythmias can result. So this is going to be a priority. We're going to first and foremost stabilize the cardiac membranes, and we do this with calcium gluconate. This is going to treat the dysrhythmias that can arise. It's going to protect that heart, but really, really important to note, it does not decrease serum potassium. It's our priority because it protects the heart, but it doesn't do anything to get that extra potassium off. And next, after we give that calcium gluconate, then we're going to treat the underlying issue of hyperkalemia. We are going to increase potassium excretion or anything that shifts potassium intracellularly. We can give a sodium zirconium, a K-exalate to increase that excretion, or give like an insulin and a dextrose to shift the potassium back into the cell. We just did an entire live on hyperkalemia. We did electrolyte imbalances specific to potassium. We covered hyper and hypokalemia. So if you have any more questions on this specifically, we have a great resource for you all. Visit our YouTube channel and check out our electrolyte imbalance live. It'll talk all about hyper and hypokalemia. All right, we also talked about having a proclivity for too much phosphate or hyperphosphatemia. So we want to decrease that, and we can do this with a calcium acetate or a calcium carbonate. And lastly, we want to treat that metabolic acidosis that we talked about that can arise from CKD. So when acid is high, we're too acidotic, we want to give more base. So this is why we would give sodium bicarbonate. You may have heard this in the hospital setting, just described as bicarb for short, but this is base. It's going to help lower the acidity, bring us back down into that range, 7.35 to 7.45, where we want our serum pH to be. Alrighty, so that was the medication part of our management, but remember, management here is twofold. Next, we're gonna look at diet. So if these clients have a proclivity for high serum amounts of certain things and low serum amounts of certain things, we're gonna have to teach these clients what they need to be eating more of and what they need to be eating less of. So important to note a couple of things here. These clients need to be on a low potassium diet because again, we have a proclivity for hyperkalemia, which means they need to avoid high potassium foods like bananas, oranges, orange juice, apples, and leafy greens like spinach and kale. We also want them to avoid phosphorus because they have a proclivity for hyperphosphatemia, so avoiding things like nuts, berries, and again, those green leafy vegetables. This diet works out well for anyone that does not like salads. And also we're gonna wanna put these clients on a low sodium diet. Remember that where sodium goes, water will follow. If we already had the potential for volume overload and this client is eating too much sodium, that can cause even more water to make its way into the intravascular space, which would further increase our blood pressure here. So for low sodium, we're avoiding those salty, processed foods, no popcorn, no French fries, no burgers, no chips, all these really yummy sounding things we are not gonna be able to consume. We're going to make sure these clients are on a fluid restriction. We don't want to add to that fluid and volume overload. And we're also going to put them on a moderate protein restriction. So I feel like sometimes this is where people get a little bit confused. Protein is a very important nutrient, and we're not saying to cut it out of their diet by any means, but breaking down that protein is a little tough on the kidneys, which in CKD we know are already struggling. We don't want to overload them more with so much protein. We want them instead to stick to lean protein sources, things like chicken, fish, turkey, and our plant-based proteins like beans and legumes. We want to avoid those heavier red meats that are super high and other things like sodium and tyramine. This includes beef, steak, and sausage, those really heavy processed meats. Again, sticking to our lean sources of protein. So to sum all that up, because it was a lot, we're going low potassium, low phosphorus, low sodium, a fluid restriction, and a moderate protein restriction for our CKD clients. So that sums up our medication as well as our diet side of twofold management of CKD. Now let's look at our nursing interventions. So a lot of those, diet restrictions are really going to be up to the clients to implement. Now let's talk about nursing interventions, more about what we can do as nurses to help treat these clients. So really important thing here, we have that potential for volume overload, so these clients will be on strict I's and O's, that intake and output. Make sure we're documenting what they're taking in and documenting what they're putting out. We want to monitor the electrolytes. We just talked about the proclivity for all of these electrolyte imbalances. So in a hospital setting, this may look like frequent lab work, especially we're keeping an eye on that potassium because we know potassium imbalances can have cardiac complications. We want to frequently assess heart and lung sounds. Lung sounds, we're looking for signs of pulmonary edema, pleural effusion, looking for those rales that we may hear. And heart sounds and continuous cardiac monitoring, we're going to be keeping an eye out for dysrhythmias related to electrolyte imbalances. We also want to do all of these things, in stages 1 through 3, preventing that disease progression. However, if it gets past that, if unfortunately these clients do end up in stage 4 or 5, we will need to prepare them for heavier interventions. So in stages 1 through 3, those diet modifications and the medications, the kidneys are still able to respond, but in 4 to 5, those stages, the kidneys are no longer doing their job and they're no longer responding. So once those kidneys are damaged beyond repair, care, unfortunately, there's nothing we can do to restore their original function, so we can supplement the function, and we do this through dialysis or transplant. So dialysis would essentially be mechanically doing the work of the kidneys through a dialysis machine, and beyond that, we would resort to a kidney transplant. Alrighty, so that sums up our content section of today's lecture. Now let's move on to our questions. And remember, we have an extra bonus question today, so stay tuned. But question number 1 asks us about diet. So the nurses taught a client with end-stage kidney disease about recommended dietary modifications. Which of the following menu selections by the client would demonstrate a correct understanding of the teaching? Is it oranges and strawberries? Or option 2, spinach salad? Option 3, grilled chicken sandwich? Or 4, tomato soup? Drop those answers in the chat. Alrighty, I see lots of answers coming in. In the meantime, so you guys know, we're putting out Nurse Life videos that answer the full spectrum of questions that come up on, how do I get into nursing school? How do I pass my ATI exams? How do I register for my NCLEX? And then on to the first few years of independent nursing practice. So check out the videos we've already posted. We also just put up one asking for y'all's questions about how to register for the NCLEX. So again, if you want to find that video, drop any questions you have about this process into the comments. We are currently working on our video responses. So if you have any questions, now is your time to shout it out. You can also put it in this chat here today. But we're always looking for more ways to help you guys, and the best way to do that is simply asking you guys what you need help with. So if you have any questions about the NCLEX registering process or the study process, let us know, and we will work on getting you guys more resources for that. Alrighty, so I see lots of answers came in. Way to go, you guys. And it looks like, by and large, you guys got it. Our correct option was number 3, that grilled chicken sandwich. So let's look at this question through the lens of what our clients in CKD are trying to avoid. So with our CKD clients, we just talked about diet. We know they're trying to avoid phosphorus, potassium, and sodium, and they're limiting their protein, and they're also on a fluid restriction. So in option 1, oranges and strawberries, well, right off the bat, we know oranges are high in potassium, so we can cross this one out. Option 2, spinach salad. So spinach is a leafy green, which means it has high levels of phosphorus, but also spinach is high in potassium. So this one's kind of like a double whammy. We can definitely cross this one out. That leads us to option 4, tomato soup. This one, tomatoes are rich in potassium. Also, soup, specifically canned soups, are typically pretty high in sodium content. So again, we can cross this out. And that leads us with option number 3, the grilled chicken sandwich. So remember, we're limiting our protein, but we're not avoiding it entirely. Instead, we're looking to get it from lean protein sources like chickens, turkeys, and fish, rather than a beef or a red meat alternative. Alrighty, so option 3 was our correct option, that grilled chicken sandwich. This is making me hungry, it's lunchtime. Let's move on to question number 2. All right, so the nurse is caring for a client with chronic kidney disease, or CKD. The nurse notes tall peak T waves on the continuous cardiac monitor. Which of the following actions would be a priority for the nurse to take? Should they, option 1, administer IV calcium gluconate to the client? 2, teach the client to limit dietary intake of potassium. 3, request a prescription for oral sodium polystyrene sulfonate for the client. Or 4, prepare the client for placement of a temporary catheter for hemodialysis. Drop those answers in the chat. Let us know what you all are thinking. Alrighty, and if you are not aware already, we are partnered with NSNA, the National Student Nurses Association. We are so excited about this partnership. Through the NSNA, we're offering 6 virtual sessions throughout the year. We just finished one last week, but we still have 5 left to go. So make sure you check our social media pages as well as NSNA's social media pages so you can stay up to date on when those are planned out throughout the year. We're also so excited to be going to the Spring NSNA Conference in Seattle. I will be there, Nurse Coley will be there, Nurse Jasmine will be there. So if you want to go in person, we'd love to see you, but there will also be virtual options for that. Alrighty, I see predominantly option number 1, but I see a couple of 2s and 3s mixed in. So let's go through this in a little bit more depth. So our correct option was option number 1. The majority of you guys got this, but this question can be a little bit tricky. So let's walk through it. Option 1 is correct because we see CKD and we see tall peaked T waves. So right off the bat, what are we worried about? We're worried about hyperkalemia, that high serum potassium causing these cardiac dysrhythmias. So our number one priority during when we see this hyperkalemia dysrhythmia, we're going to want to stabilize the myocardial cell membranes and protect the heart. So we're going to give IV calcium gluconate because that is the indication of this medication. It has a very rapid onset. It works in 1 to 2 minutes, but our absolute number one priority is to stabilize those cardiac membranes. The rest of the options, I know this is confusing because of course this dysrhythmia happens because of hyperkalemia, and the rest of the options talk more about limiting potassium, but our number one priority is going to be stabilizing the heart, and then we're going to work to decrease our potassium. But also important to note is that calcium gluconate does not do anything to decrease our potassium levels, it simply protects the heart. That is our priority in this case. Option 2, 3, and 4 get at decreasing that potassium, but they're not going to be our priority. So option 2, teaching them to limit the dietary intake of potassium. This is something that we would do. It is important, but it's not going to immediately decrease that potassium, and it's not going to stabilize the cardiac cell membranes, so it's not our priority. Also, option 3, request a prescription for oral sodium polystyrene sulfonate for the client. This is K-exolate. It encourages the GI excretion of potassium. Of course, we do want to decrease our serum potassium levels, but first, we're always going to protect the heart and stabilize those membranes, so this is not what we're going to do first. Also, this GI excretion of potassium can take anywhere between 1 to 24 hours, so not a very quick onset of action. And lastly, prepare the client for placement of temporary catheter for hemodialysis. Again, dialysis can supplement the kidney function with a mechanical dialysis machine. It's not a priority above stabilizing and protecting the heart, but we can get potassium off with dialysis after we give that IV calcium gluconate. Alrighty, so that was tough, but you guys did really well. I'm gonna check the chat. And I see someone asking, sodium polystyrene, it is used to treat hyperkalemia. You are absolutely correct, but it doesn't do anything to protect the heart. Remember our ABCs, airway, breathing, circulation. Dysrhythmias are going to affect the C of that circulation. So we're going to treat that first before we work to get that potassium off. Alrighty, so question number 3. Doing great, you guys. So question 3 says the nurse is caring for assigned clients. The nurse should first assess the client who has option 1, nephrolithiasis and hematuria, 2, AKI and elevated serum potassium level, 3, a UTI and pyuria, or 4, chronic kidney disease and a decreased glomerular filtration rate, So this is a more general question. We're taking the knowledge that we learned today and we're applying it in a broader sense. This is exactly what the NCLEX will challenge you guys to do. So I know you guys got this. I hope some of these terms look very, very familiar to you because we talked about a lot of them today. Alrighty, and kind of a similar teaching point to the last one, but I see lots of answers coming in. Way to go, you guys. Thank you so much. We love to see everyone participates, but you guys are by and large absolutely correct. Way to go. So option 2 was our correct option, AKI or acute kidney injury and an elevated serum potassium level. So why is this correct? We know that elevated serum potassium can cause cardiac complications. We just spoke about this in depth. So it can include those peak T waves, prolonged QRS complexes, and we're always thinking back to our ABCs, airway, breathing, circulation. This affects the C of those ABCs or our circulation because of the potential for cardiac dysrhythmias. So a general test-taking tip here, if you ever see the word acute or new onset or something that signifies a change from baseline, this is going to be a green flag question of this what might be our correct option. Again, this is going to be a need for priority intervention if anything is acute or new or sudden. Alrighty, so again, option number 2 was our correct option. Option 1, nephrolithiasis and hematuria. So this is just a kidney stone, and while they're very, very painful, hematuria is blood in the urine. We can see this in a kidney stone client. Of course, this is an unpleasant finding, but it's an expected finding. So another test-taking tip here is to try and filter through what is a complication that needs further intervention versus what is an expected finding. So we would expect to have a little blood in the urine in a kidney stone client, so option 1 can be crossed out. Option 3, a UTI and pyorrhea. So in a urinary tract infection, we can see pyorrhea, which is just pus in the urine. Again, this is an unpleasant finding, but it is expected. We would treat this client with an antibiotic and probably some pain management, some analgesia, but this is not our priority. And lastly, option 4, CKD and a decreased glomerular filtration rate. I hope you all were very familiar with this because we have just spent today talking about it, but every single stage in chronic kidney disease, being stages 1 through stages 5, include a decrease in glomerular filtration rate. That decrease just gets worse and worse as we go through the stages. So again, this is an expected finding of a client in CKD. So again, our correct option was option number 2 because it indicates a complication. Great job, you guys. So we're going to go ahead and hop to a QBank slide. For all of our users and viewers that have already purchased UWorld, here is how you get more questions to test the knowledge that we've learned today, more GU, kidney, renal kind of questions. So you can simply screenshot this, go into our QBank, and select the same subjects and systems to get more questions on what we learned about today. And lastly, thank you guys so much for staying tuned. I hope you find this helpful. The kidneys and the renal system can be pretty complex, so I hope breaking it down today really helped you all. Join us again tomorrow as well as Thursday for question drills. We'll be covering ECGs tomorrow, so all of those ECG strips that I know a lot of us sometimes struggle with. And lastly, we're going to be covering oncology questions on Thursday. So join us again Wednesday and Thursday at 11 a.m. and 3 p.m. Central Standard Time. Thank you so much for tuning in. Have a great rest of your day.